Good morning everyone. I thought I will kickstart the video pause with the very first talk. This is a reappraisal of the importance of using Compass risk assessment score for patients with hip fractures. Thanks to Mike and Andrea for their hard work. So, why do you want to risk predict? Risk prediction is done to identify patients who are at higher risk of dying within the next 30 days and possibly longer than that. Knowing this would be helpful for both us and the patients and their relatives. It can direct the conversation around consent for surgery, TEP form completion, care planning, including appropriateness to go to intensive care after surgery, and to do something tangible preoperatively to optimize them to go through surgery better. Would it not be nice to have a tool that will measure if we have optimize the patient for surgery or not? Are there any tools for risk prediction? Yes, of course, there are numerous tools, but many of them are clunky to use or too simplistic and does not give a true physiological compromise of a patient. Nottingham Hip Fracture Score is one of the most popular one, so much so that one is expected to complete this while submitting the data to the National Hip Fracture Database. By doing this, you can divide the patient into two groups, a low risk and a high risk group. Low risk patients have a predicted mortality of 3.5% at 30 days and 13.7% at 1 year, whereas the high risk group patients have a mortality of 15.9% at 30 days and 45.5% at similar time scale. What are the differences between Nottingham Hip Fracture Score and Compass? What makes up the score? In the Nottingham Hip Fracture Score, it uses 7 variables, whereas Compass uses 16 variables. Apart from hemoglobin, none of the variables in the Nottingham Hip Fracture Score could be modified in short term, and therefore it is not easy to measure any optimization. But with Compass Score, there are potentially 8 variables one can change in a short period of time with appropriate medical management, and redoing the score after this could be a surrogate marker for optimization. Perhaps sodium is one thing one may not be able to change within 24 hours. To understand why 30-day mortality is important for the trust, one has to have a look at the National Hip Fracture Database, where details from every hospital in England is displayed in the public domain. This almost comes out as a league table of good and bad hospitals. Here is a screen grab of our hospital. To understand the bars and the lines, I have placed some pointers. The vertical blue bar gives you the total number of patients admitted per month. The black triangle with line at the bottom is the 30-day mortality for our hospital. The thin dotted line is the national average for 30-day mortality. The two red lines at the top are the time to theatre. One, which is in bold, is our time to theatre, and the thin dotted line is the national average. There is a constant pressure on the services to get patients to theatre within the 36 hours after admission, but clearly this may not be appropriate to all patients. How do we therefore identify which patients could go to theatre safely within the time frame without undue risk, and who could benefit from optimization or improvement of their medical condition, and who cannot be made better within a short period of time, even with treatment? This is where I think use of Compass Score comes into play. Let me show you what we found. We did a retrospective analysis of Compass Score of 686 patients on admission and mapped their short-term and long-term outcome. Outcome being mortality, as this is a clearly identifiable endpoint, especially in a retrospective analysis. The period we covered was for 18 months between April 2015 and September 2016. All patients had a follow-up on the electronic portal system to determine the outcome, and this was last checked in January 2020. Among the 686 patients, there were more female patients with hip fracture and the average age for each group was roughly the same. All but 11 patients received operations for their fracture. Now for the headline news. Out of our 686 patients, 44 died within 30 days, i.e. 6.4% mortality. Nearly 26% died within a year, 36% died within 2 years, and so far 42.4% patients have died at the last virtual follow-up in January 2020. The average age at death was 87 years. Of those who were treated non-operatively, 3/4 of them died within 2 weeks after admission. Credit to the team making the judgment for these patients and not subjecting them to an unnecessary operation. Literature tells us that males die more than the females. This is also true for COVID infections. At 30 days, 7.4% males died in comparison to 5.9% females, and at 1 year it was 31.3 versus 23.5, and the rest are on the table. This is an information heavy slide, and I will try to make it easy for you to understand. I will reveal different sections one by one. The top row is the parameter that we are going to compare. The first vertical column on the left shows the mortality risk predictions done by Compass. I have grouped them into 5 as shown. I have named these groups based on the risk of death. The total number of patients in each group as predicted by the Compass on admission is given in the next column. Thankfully, we did not have many admissions of patients in critically ill group. To make it easy to compare, I have changed the numbers to percentage of admission. As you can see, 85% of patients belong to the low to high risk group. At 30 days, less than 2% died when the risk prediction at admission was within 5% or less. However, it significantly increased for the other 3 groups. 10% for high risk, doubling to about 20% for the very high risk group, and nearly 1/3 of the critically ill group unfortunately passed away within 30 days. I will simply reveal the numbers for the 90 days and 6 months, and let's go to the first year. At first year, the first group had about 11% mortality, and roughly add 10% to that for every group except for the critical ill group, where you add 20% more than the preceding group. One can see that there is a clear separation between these groups as time goes by. This is another way of showing what is really happening in a bar graph way. At 30 days, one can see the number of patients who are alive as given in green bar. At 1 year, it changes, and the green bars get shorter for high risk group, and at 2 years, you can see that the separation between these 2 groups are rather clear. I was unable to generate a Kaplan-Meier type survivor analysis line chart on the Excel sheet, but this is my best attempt. But I hope this gives you an idea about the differences between the 5 groups. From this analysis, I conclude that the mortality risk compares to the Compass score at admission. I have given you a ballpark figure to make it easy to remember when you do the score at the time of the admission of a patient. Please remember, it does not mean that any patient with a score less than 2% will not die within the next 30 days. It is just that their odds are much better than another patient who has a score, say, of 15% mortality prediction on admission. The second take-home message is males have a slightly higher mortality rate than females at any time interval. By using Compass score at admission, you can understand the patient's physiological status, which is a surrogate marker for predicting mortality risk both short and long term. I would want to stress that Compass score was not developed to predict long-term mortality. It is validated for 30-day mortality based on over 15 million HES data. By doing the Compass score at admission, one can have a more informed consent discussion, plan appropriate support they need both pre and post-op, decide if they need an intensive care support post-operatively, and will also be helpful to complete the TEP forms. But the drive I have for the Compass score is to use this as a tool for optimizing patients. This will also help us to decide which patient can be taken to theatre as quickly as possible and which ones might require optimization to help them to go through the surgery safely. In other words, it will make us to stop and think about each patient rather than blindly saying all patients will have to go to theatre as soon as possible. Of course, some patients cannot be optimized and some might not need any optimization, so both these groups can be considered for surgery as soon as possible. Please do use Dr. Papin's A3 chart, which spells out the optimization protocols. It remains to be seen with prospective audit if optimization has any influence in decreasing predicted 30-day mortality. So can I please request you to do Compass score on admission for all patients, and if you do delay surgery or optimize a patient, then please do rescore them within 24 hours. Thank you very much, and if you have any questions, fire them up on the comment section. I really appreciate it.